Thank you. So I'm going to introduce the next speaker, Professor Irfan Ahmed. Whilst he's on a long-term career break from NHS Grimpian Aberdeen, Irfan is currently working as a HPB consultant and director of research at Pakistan Kidney and Liver Institute and Research Center, Lahore, Pakistan. He has helped introduce robotic surgery in Saudi Arabia, Pakistan, and Scotland. Irfan holds personal chairs in University of Aberdeen, as well as Gordon University in Scotland. He's instrumental in active international collaborations to push for global health equity in surgery and academia. Thank you very much, Irfan. Over to you.
Thank you very much for the introduction. And Jawad, thank you very much for inviting me today. I would like all of you to have a look at this topic, which sits at the interaction of innovation, medicine, and global health inequality. So today's conversation is not going to be about futuristic innovation, but how we can bridge the gap of global inequality in healthcare across the world. So we are going to talk about promise of robotic surgery all day if we ignore the last talk, which I thoroughly enjoyed, because we all say that robotic surgery is going to come up with increased patient satisfaction, better outcome for them. Problem is that this is going to increase the cost and the resource deprived countries are going to be left behind. Now, World Bank every year classify countries into 4 different income groups: high income, upper middle income, lower middle income, and lower income. So the countries which are in purple here are LMIC countries. With dark purple, the low income countries, and the light purple, low middle income countries. And their gross national income per capita is just around under $4,200. So robotic surgery has got a very short history, as we all know. I think it was around 2000 when Intuitive or Da Vinci came up and started pushing robotic surgery. But then since then, too many companies have come on the bandwagon to benefit from this. This slide was given to me by my colleague, Spanish colleague, 6 months ago. And these are the established system in post-Da Vinci era, which has come in the market. And this list is not complete. There are more than 100 new startup companies registered to market their robotic systems. And so there are modular systems, Da Vinci-like, single port, flexible, single boom, Magna robot, combined system. But interesting thing is, if you look at the maps next to these companies, China is now leading this race after USA. And they're coming up with more cheaper and more innovative robotic systems. Now, this painting, which is currently in Tate's Museum in London, was made in 1889 by Luke Fildes, the doctor, which shows a medical man sitting next to an ailing child and parents just trying to look for any last hope for their children. Now, this helplessness is palpable across half of the world, especially in remote and rural areas, when help do not reach those communities. So imagine in a rural village where a girl needs a life-changing or life-saving operation, but the surgeon who can perform this operation is hundreds of miles away in a different city or maybe in a different country. What if that operation can be performed remotely? So I think that's where the robotic surgery can come into play for LMIC countries. But how far we are from this fantasy, turning this fantasy into reality. So I'll just tell you about my personal journey. I don't call myself as a robotic surgeon, but I've been chasing robot. Robot has been chasing me along my career. So in 2011, I was part of a charity in Aberdeen to get the first surgical robot for our hospital. So after 2 years, we collected the money, got the robot, but only urologists could start doing robotic surgery because there was no evidence for HPB surgeons to start robotic surgery. So I was left behind. Then I took a career break in 2018 and went to King Faisal Specialist Hospital in Jeddah, where I convinced them to buy a robot, started robotic HPB surgery there, but after a year I turned back to Scotland. So in Scotland, I became part of RAS group, Robotic Assisted Surgery group. We lobbied the government to buy a robot. They sanctioned 20 million pounds and 10 robots were bought in 2021. But in 2021, because of my parents' health, I have to move to Pakistan. There I convinced them to buy a robot for the hospital in my current hospital. And we started performing first ever robotic surgery there. But that is an LMIC country. That's when I became aware of the problems in LMIC country of introducing the robotic program. And I'm grateful to Jawad, I think he's left the room. He traveled on his own expense to Pakistan to proctor us to start robotic HPB surgery. So there are lots and lots and lots of challenges. And again, we can't talk about them in my 10-minute talk, but these are the top 4 which I've highlighted while setting up this in Pakistan. So the first thing, when you start talking about robot in LMIC country, it's always thought of as luxury in the backdrop of poverty. A robot costs $2 million. And then there is cost of training and regular maintenance. So $2 million is more than an annual budget of a whole public hospital in Pakistan, where I am. Running one robotic surgery costs us $1,500. With that amount of money, you can do 10 open surgeries. So justifying that cost can become very, very difficult for the decision makers there. So the other thing is lack of skilled workers, and that's a big problem for half of the world. So concentrate on LMIC countries who have got much fewer trained surgeons than the minimal threshold set by WHO. So, and that's because of migration. People migrate from LMIC countries to high-income countries for various reasons, for political instability, for ongoing wars, career progression, economic benefits. But that's the gross movement towards high-income countries, which is quite alarming. So all the skilled workforce moves to high-income country. And then when we look at UK, where we are actually sitting right now, the top 5 people who migrate to UK are from low and middle income countries. So that becomes a major concern for those countries to keep up with the skilled workforce, because without skilled workforce, you cannot push the boundaries and you cannot introduce these things. That is an interesting one, because I talked about telesurgery, but for telesurgery and robotic surgery, you need stable electricity and internet connections. Most of the hospitals have got long-standing electricity outages, no uninterrupted power supply, unreliable internet systems. So running these high technological systems can become a big problem. And then a 2-tier health system is prevalent in LMIC countries. Very few wealthy population can afford to go to private hospitals to get the top-end treatment, but most of the poor go to public hospitals where there are no resources. So traditional methods have to be followed for their treatment. So establishing that 2-tier system can become an ethical question. So what are the solutions? I think there's no one solution. This is more of creating awareness of this inequality. LMIC cannot afford the current robotic models, and I'm talking about Intuitive, Da Vinci, or maybe the other surgical systems like CMR. So more cost-effective models have to be developed, and China is leading the way to develop those models which are coming up. Leasing is not an issue in LMIC countries. You have to buy the robot upfront. And then coming up with new ideas that how you are going to use this new technology. Now, everybody starts talking about robot. They want to get trained in robot, but they know that if they train in robot, they're never going to go back to their own countries. Now, robot is coming up. There are lots of local systems which are coming up through startup companies in LMIC countries, which are cheap, they're easy to run, but there are very small countries which are bringing them up. And I gave an example of smartphones. High-income countries lead the way in smartphone ownership, but LMIC countries have now got smartphones, but they are not your standard Apple and Samsung phones. These are the phones which are 1/5 of the cost, made by other local companies, or mostly come from China, and they're infiltrating the market with the same functionality and 1/5 the price. But the big thing which we talked about there is for LMIC country, we do not have to move down the route of taking open to laparoscopic to robotic. I think the biggest advantage which we know is converting open into robotic surgery to give patients the advantage of minimal invasive surgery. And what we can do laparoscopic should remain laparoscopic. The big thing which we are doing in Pakistan is public-private partnership. So establishing shared robotic platform where private patients can come and even public hospitals can benefit from it. So this strategic public-private partnership is essential. Apollo Hospital in India has started doing it, and it is very successful in introducing robotic surgery to people who cannot afford. The vision of introducing telesurgery and robotic surgery in which a surgeon in a major city or major hospital can perform operations remotely. And in 2022, this was published about transcontinental surgery, but this was in high-income countries. But I was following this just last week, that in India, they are performing cardiac surgery remotely, and this might be one of those things, one of those first things which might come to bridge the gap between rich and poor. Now, ethical use of robotic surgery is important, and I'm glad that some of the robotic companies are giving governance guidelines, and Jawad has helped some of those guidelines already for the ethical use of robotic surgery in LMIC country, because these cost-effective systems can flood the market, but then everybody will start using them without any governance structure. So in conclusion, I think there are lots of challenges. It's important to be aware of those challenges, but there are some potential solutions. And by incorporating those potential solutions, LMIC country can slowly integrate robotics into the existing healthcare system. And I think the strategic investment and upcoming innovation in technology will help bring the gap or close the gap of health equality in LMIC country where half of the world population resides. Thank you very much.
Hi, Irfan. It's a good talk. This is Neil from Sheffield. In your last slide, you alluded about the telesurgery. So SSI Mantra has been there in India. Professor Rella would probably able to say more, but I come from Gujarat state originally, and I've got a couple of, so they do a lot of robotic and surgeries on SSI Mantra, and they have even in public hospitals. So the gap, as you said, is bridging. And they've started performing telesurgeries as well. But I agree that because the cost is it's 1/4 or 1/5 the cost of Da Vinci robot performing same surgeries. And there are lots of other Chinese companies which are coming in as well. And the guidelines are there to develop, otherwise it will be flooded, as you said. But I think the gap is bridging very fast, I think.
I completely agree with your comment, and I think that's where we need to bridge that gap so that LMIC countries do not fall far behind. So I agree with your comment.
Irfan, just a quick question. So thank you. Excellent talk. So I think just regarding the sort of shift of professional workers from LMIC countries to more affluent countries, I think that will sort itself out. Now Donald Trump is in power. He's going to send them all back. But just looking back at LMIC countries, I mean, I don't want to take trade away from our colleagues in London, but you get a lot of people travel to Western countries, London, USA for surgery from LMIC countries. Is there any potential to develop a market where you can treat them in the LMIC countries? Because I know for a fact a surgeon in the UK has gone back to Nigeria. He's a urologist. He's found an old SI, which he's using in a hospital in Lagos in Nigeria to do prostatectomies. So he may capture the market of people who would have otherwise gone to Harley Street. Is that something possible, do you think?
I think that's talked about quite a lot actually these days, health tourism, which we call it. But then this will require establishing strategic partnerships, because you need the right governance for those people who are traveling, and then sharing all the medical records between two countries. So these partnerships are essential, and I think this is happening in some of the countries right now.
Thank you very much.